Good afternoon, everyone. I am Caterina Antoniou from Heraklion, Crete, Greece. I'm the secretary of the Assembly 12, the interstitial lung disease of European Respiratory Society. And it is my great pleasure and honor to host you in this exciting webinar that we will share a lot of exciting novelties in connective tissue disorders and interstitial lung disease. It is my honor to introduce Professor Bruno Crestani, who will co-chair the event with me. Professor Crestani does not need an introduction. He is Professor of Respiratory Medicine in Paris, gold medalist from the ERS, and I could say that I have met him in 2005 through an article in allergy about CTD-ILD when I was doing my PhD with my postdoc research with Professor Wells at the Brompton in connective tissue disorders and smoking relationships. Maybe he doesn't know that. So my pleasure, and the floor is to Bruno.
Thank you very much, Katerina, for the nice introduction. So I will keep it short, and I think we have the current situation is absolutely incredible. There are so many progress occurring right now in the field of connective tissue disease, ILD, which I think will remain the future as a golden period. We have really very good data coming out, and our speakers today will go through, and I think we will be very excited at the end of this session, more than I am right now already. So I will introduce Professor Elena Bargali. Elena Bargali is from Siena in Italy, and she will have a difficult task, I would say, to help us predict the future, because she will talk about how to predict outcomes in CTD-ILD. CTD means connective tissue disease, interstitial lung disease. So Professor Bargali, thank you very much for coming with us today with these outstanding participants online. Thank you, Elena.
So thanks to you.
These three questions, sorry.
Oh, sorry, yes. Yeah. I was a bit quick. We wanted you to answer a few questions which appear here that we prepared with Professor Antonio. You will be able to vote right now at the beginning of a session, and we will see at the end of a session if you change your mind about this very, I think, some important question. So please, you can vote on these three questions. One is about markers of progression in ILD. The second is about treatment in CTD-ILD, and the third one is about treatment of scleroderma ILD. So maybe, Ali, you can explain our participant the way they should go. I think it's very easy. You can
yes,
click.
It's really straightforward, and they are voting now.
Yeah, so you click and
yeah, they choose the option and they vote. Yeah,
yeah, quite easy. Huh? I already voted myself. Just to say.
Do you know the answers?
Ah, we will see at the end. So it's very interesting. A marker of progression of ILD, there is a discussion between DLCO and FVC, we understand, no? Mm-hmm. What about the treatment? We see that the combination of immunomodulator and antifibrotic comes first before steroids. And how to treat scleroderma patients, we see that there is a big success for mycophenolate, and we will see at the end how it goes. Thank you so much for voting, and I think now we can move to Professor Bargali.
And so thanks a lot, thanks Bruno, thanks really European Respiratory Society for the opportunity to meet all these people from all around the world. So it's really a special thank, and especially for Professor Antonio that managed all this kind of relationship and helped us to be in contact and to focus on one of the main topics of research. So as already discussed by Professor Crestani, this is a really novel topic of research. So a really special thanks to Elisabeth Renzoni that gave me the opportunity to be here and also that helped me in the preparation of the slide. So she improved my work and also she suggested me some very recent and relevant topics on this field, because it's something that really is changing a lot, is modifying, is improving, and now we have really a lot of results and data about the predicting outcome in connective tissue interstitial lung diseases. So why we have to be interested in predicting outcomes in ELD? So as Professor Crestani told us, we will really need to discover the future of our patients. So I think that rheumatologists and ophthalmologists share the same question. So why it's important to assess interstitial lung disease in connective tissue disease patients? So which is the relevance to understand if a lung involvement occurs in patients with rheumatoid arthritis or systemic sclerosis or other connective tissue diseases. So it's really important to know if lung is involved, if we can discover an interstitial lung disease, because that can impact, can influence prognosis, treatment, and also can change the follow-up and the decision, the therapeutic decision of our patients. So the awareness of extrathoracic involvement is something that is really very, very relevant. So it's important that rheumatologists can focus on this lung involvement on this part. So we can choose as a prototypical connective tissue disease with a very frequent and very relevant interstitial lung disease, a very important disorder that is generally common in female, that is systemic sclerosis. So we can decide that systemic sclerosis research and studies can make a sort of difference. So they can explain us what can happen in autoimmune disease in which the interstitial lung disease can occur. So we have to decide that systemic sclerosis is probably one of the most relevant fields of research in this moment. And the interstitial lung disease involvement can occur in the majority, in most patients with scleroderma. In particular, in about 30% of patients can be really clinically significant, can have a variable severity. So interstitial lung disease involvement may represent the main cause of death. And it's really very relevant and important to be discovered, because now, as we can understand from the recent clinical trials, we can have also specific treatment for interstitial lung disease occurring in systemic sclerosis. And the most relevant and most common radiological pattern that we can observe in CT scan is generally non-specific interstitial pneumonia. So this is not the only feature that we can observe in CT scan, and we generally can observe different kind of pattern, but non-specific interstitial pneumonia can be considered the most frequent one. So the relevance of lung function test for predicting outcomes in systemic sclerosis, that's really a great topic. And so as we have already asked in our first question, the most important predicting outcomes can be considered, for example, for pulmonologists, can be considered a lung function test. But if we look to the literature, we can observe that lung function tests have a poor performance to assess the presence and the severity of ELD. In particular, obviously, FVC and the LCO are really very important, but the analysis of FVC can create some risk of missing significant interstitial lung disease or overestimating. So we know that FVC can be modified by different patterns, by different diseases, and can sometimes be modified in a very late phase of the disease, while the LCO can be modified also for other causes, not only interstitial lung disease, but for example, for pulmonary vasculatory involvement. So for example, so our behavior, our way of thinking has to be that also radiological features can be really very important and very informative. So we have to know that sometimes it's very hard to discriminate the radiological involvement in CT scan from systemic sclerosis associated with interstitial lung disease. And in particular, we have to decide if our patient has a limited form of interstitial lung involvement, have an extensive form of interstitial lung involvement, or if it can have a sort of indeterminate involvement. And in particular, we have got a very nice manuscript from the American Journal of Respiratory Critical Care Med that discriminated the survival of patients according to the limited involvement at CT scan from interstitial lung disease or an extensive form of CT scan. So we can see the main difference of survival from patients with a limited interstitial lung involvement compared with patients with very extensive interstitial lung disease. And we can see also the association with the correlation with lung function test, and in particular with the FVC percentages. Other predictors of SSC-ILD can be really very wide. So we all know the relevance of the autoantibodies analysis. In particular, it's really very relevant to analyze autoantibodies not only for the diagnosis, but also to predict outcome in systemic sclerosis. Other predictors of prognosis, of progression, can also be considered the skin involvement, in particular diffuse skin disease is associated with poor prognosis, as well as the progression of a lung function test deterioration. So if we observe a short-term lung function worsening, it means that the prognosis of our patient can be very poor. Also, another relevant aspect is the 6-minute walking test. So if we discover that there is a relevant desaturation in patients during 6-minute walking test, we can observe a poor prognosis and a high risk of interstitial lung disease progression in our systemic sclerosis patient. And another relevant and most recent observation is the association between pleuron parenchymal fibroelastosis and the prognosis of systemic sclerosis associated with interstitial lung disease. In particular, the pattern of PPFE can be associated with a poor prognosis and a high risk of death. Another really relevant, obviously, predictors of progression is also the association with other comorbidities, and in particular, the development of pulmonary hypertension. So that's a very nice description of a proportion of patients reaching FVC reduced than 80% that can predicted since onset of Raynaud syndrome, according to autoantibodies and cutaneous involvement. So in this manuscript, in this publication, it was clearly demonstrated that the association of different patterns of different risk factors can modify the modify the prediction of the progression of interstitial lung disease in systemic sclerosis. Quindi not only lung function test, but also the onset of Raynaud syndrome, the association of specific autoantibodies, and the wide and diffuse cutaneous involvement. There's another really relevant manuscript from Professor Wells and from Professor Renzoni. We can discuss with her their own results, in which the short-term pulmonary function trends can be widely associated and demonstrated predictive of mortality in patients with interstitial lung disease and systemic sclerosis, and in particular the decline of FVC greater than 10% or a composite pattern of FVC decline between 5 and 9% and decline of the LCO greater than 50% can be represented of a high risk of mortality, can predict the survival in extensive disease, while a decline of the LCO greater than 50% at 2 years can be a strong predictor of mortality, especially in patients with in the overall group of SSC-ILD. A most recent evaluation of radiological interstitial lung involvement in systemic sclerodermic patients have been evaluated by caliper analysis. So very recently, Professor Wells and other colleagues demonstrated that the evaluation of interstitial lung involvement and the automatic stratification of caliper CT variables can represent a novel method to define the predicting outcomes in interstitial lung disease associated with systemic sclerosis. In particular, this kind of modern models can amplify the possibility to define the prognosis of our patients. So putting all together different variables obtained by caliper, and so analyzing the quantity, the width and the extension of interstitial lung involvement, we can predict the mortality in our patients. A very recent study from Bonifazi and al., in which Professor Renzoni collected a very wide population of patients. So it was demonstrated that the association that between systemic sclerosis and interstitial lung disease involvement and PPFE can be really relevant for the prognostic impact of our patients. So this kind of radiological involvement generally is associated with worse survival. And if also after statistical analysis with adjustment for age, gender, and different cohort with different interstitial lung disease pattern and severity, can clearly demonstrate that when we found this kind of radiological involvement in systemic sclerosis patients, we have to think about the prognosis of our patients. So in this kind of study, they clearly demonstrated that it's a negative prognostic factor, the presence of PPFE in patients with interstitial lung disease associated with systemic sclerosis. And these novel features of interstitial lung disease is something that is probably related to a poor prognosis also in other interstitial lung disease, also in other patients. So one of the questions that we can pose is, so the predicting outcomes in connective tissue ILD can include, as we have already observed, the lung function test as well as the radiological involvement. So both of this kind of involvement, of this kind of analysis are really relevant. So lung function test, radiological involvement, both of them or none of them. So I think we have already answered. And the answer is something that is really a little bit different from the first one. Exactly. So we need both of them to really understand what kind of outcome can have our patients, because the lung function tests are really relevant, but also radiological involvement and the presence of a diffuse disease is really very important to define the prognosis of our patient. So, okay. No, I think there's something, okay. Okay, so another aspect that is really relevant is the role of biomarkers, and in particular serological biomarkers in patients with systemic sclerosis and interstitial lung involvement is something really very important. So if we put together lung function test deterioration and the evolution of lung function test, and particularly DLCO decline, in two large cohorts of patients with systemic sclerosis, we can observe that also the role of KL6 is really relevant. So when we found a very high concentration of KL6 in serum from patients with systemic sclerosis and ILD, we can observe a worse deterioration, a worse outcome in our patients. And so patients with very high concentration of KL6 are associated with probably a great interstitial lung involvement and a high risk of decline in our patients. So why KL6? Because KL6 is one of the main biomarker of lung injury and of interstitial lung involvement in all kind of interstitial lung disease, mainly in connective tissue lung disorder, in which it has been proved to be to have a predictive value in patients according to high risk of deterioration in lung function test and also of survival. So patients with high concentration of KL6 can also have a higher risk of acute phases of a disease and a lower answer to treatment. That's a very nice and interesting feature to understand if KL6 can monitor the prognosis of our patient, also the answer to treatment. And in a very small cohort compared to that of Bonifazi and Renzoni, we try to analyze KL6 behavior in patients with the association of PPFE and interstitial lung disease and systemic sclerosis. And we found that patients with very high concentration of KL6 had also PPFE involvement at CT scan. So KL6 was also able to also to differentiate patients with a low progression compared with patients with a very rapid progression due to PPFE association with interstitial lung disease involvement. So serial measurement of KL6 in more than 6 or 9 years in the follow-up can be useful to monitor our patient and also to observe that the association of ELD, SSG, and PPFE can have a worse prognosis, in particular in those patients with concentration of KL6 tend to increase with a very high trend in the follow-up. So it's recommended that the rheumatologists take care not only of lung function test, but also to the CT scan involvement. They have to take care of serological biomarkers, including, for example, KL6, that can have a prognostic value, that can really help to monitor their own patient to predict outcome in connective tissue in ELD patients. So another aspect that can be found in the very recent literature, this is something very new, is the association of the effect of the presence of emphysema in patients with connective tissue in interstitial lung disease patients. So this association has been related with a worse prognosis, and in particular the presence of emphysema in the upper lobes associated with the presence of different pattern of interstitial lung disease in the lower lobe can be indicative of a negative prognosis. Another aspect that is really very important, as you can imagine and expect, and it can be demonstrated in different manuscripts, is that the WIPI pattern, so the association of a pattern of usual interstitial pneumonia in interstitial lung disease associated with systemic sclerosis, can really be a negative prognosis, can be really association with a worse survival. And also another interesting aspect is the genetic opportunity and possibility to predict the outcome of patients according to the presence of a special polymorphism, as we all know, this is that of MUC5B promoter polymorphism that is associated, that has been studied not only in scleroderma, but also in rheumatoid arthritis and compared also with another disease that is sarcoidosis. So also genetic studies can really help us to define the predicting outcomes in connective tissue interstitial lung disease. Looking to the past, not something very new, in the past we also analyzed bronchoalveolar lavage fissures to understand the prognosis of our patient to better define the evolution of the disease. So for example, there were a relevant study in the past that verified the role, for example, of alveolar neutrophilia in patients with systemic sclerosis and interstitial lung disease. And so in the past we were looking for the cytology. Now we are mainly looking to in a panel of biomarkers present at the bronchoalveolar lavage level in order to define if not only a single cytological analysis can help us to predict the outcome of our patient, but mainly a group of panel of biomarkers, a group of bioindicators can help us to predict the outcome of our patient. Very recently, for example, in our lab, we analyzed a sort of tree of analysis that helps us with a statistical research to verify the role, for example, CD4-CD8 ratio in lymphocytosis associated, for example, with the expression of special NK cells. So I think that I have to stop here to give obviously the moderation to Caterina and Professor Pestani, and a special thanks really to my colleagues, Professor Renzoni and Professor Antonio, that are very nice and fantastic female and also very nice colleagues, and especially for Elizabeth, thank you a lot for all kind of teaching that you give us about systemic sclerosis and interstitial lung disease. Thank you so much.
So thank you, Elena. Exciting talk. Keep the questions for Elena at the end because we have to go now to the, I think, exciting, it will not be a debate. However, you will see that we will have a rheumatologist, and Elizabeth Renzoni, the pulmonologist in the same room, and they will share with us the most exciting treatment advances in the field. And it is my pleasure and honor to have with us, within ERS, Professor Oliver Distler from the University of Zurich, extinguished colleague in rheumatology, but also, I think, in pulmonology. and he will share with us his latest advances in the field. Some of these treatment advances will leading by him and distinguished colleagues. So Oliver, the floor is yours, and thank you so much for being with us this evening.
Thank you, Katarina. That is so kind what you are saying, and you know, I'm so excited about ILD. I have to say I have no idea about other pulmonology topics, I have to admit, but maybe I should apply for a honorary specialization at some time because I find it so exciting. Thank you for inviting me. My disclosures, which are relevant because we talk about therapies. And this is the introductory slide, just to start with a definition of the CTDs we talk about. And what you are seeing is actually that we talk about different prevalences, being almost 50% prevalence in scleroderma for ILD, down to RA, where it's probably, depending on what cohort you look at, but probably around 2% or even less. But the disease is much more frequent. And so in total numbers, this makes probably the additional most relevant connective tissue disease, ILD, that we are talking about. So one has to say that the level of evidence, and Elena already alluded to that, is mostly coming from systemic sclerosis. So in our talk, also Elizabeth's second talk, many data will come from systemic sclerosis just because we have a much better evidence there. And on the next slide, we had a discussion with Elizabeth. So, you know, there are so many treatments discussed. How do we select them in only 21 minutes to present to you? And what we decided is we will only present medications to you that have been analyzed in randomized controlled clinical trials, because then we can truly provide you some evidence. And this is what Bruno said at the beginning, really the breakthrough, that we have now many medications where we can present you something. And this is the list, and Elizabeth and I have divided this a little bit. So you will hear from nintedanib, from me, and from Tocilizumab and rituximab, and Elizabeth will add on nintedanib and add also cyclophosphamide and MMF. And also, of course, we also do some general considerations. So let's straight go into it. Nintedanib. This is the census trial that led to registration of nintedanib in scleroderma ILD. You see the primary endpoint is forced vital capacity, and in the placebo group, there was a 90 milliliter progression. And this was 52 in the nintedanib group after 1 year. This is a significant difference. What is important to recognize here, that this was a relatively broad population of scleroderma ILD patients, not really strongly enriched. We see that when we compare that to our real life registry, that is a relatively representative cohort, which we would consider for treatment. And as a adverse side effect, so to say, this is not rapidly progressing, right? Think about IPF, which is your disease, how much progression you have under placebo there. Here it's only 90 milliliters. And what you also have to understand, that 90 milliliters is below the minimally clinically important difference. So if you ask on average, of course, there's a wide spread of progression or even slight improvement, but on average, if you ask a patient with 90 milliliter decrease, do you feel worse? He would say no after 1 year, because the MCID is around 120 milliliters. This is important to understand, because there's a lot of discussion if that is clinically meaningful, the difference we are seeing here. It can't be meaningful, because even the placebo group would not realize that they are worsening over 1 year. But we also know this is continuing for 2 years, 3 years, 4 years, and then it's adding up. And then, of course, it becomes clinically relevant. So immediately a question is, this 1 year difference is probably not realized by a patient in this slowly progressing scleroderma ILD cohort. But if it continues, it would maybe become clinically relevant. So let's have a look at this, because there are more data now available that have been presented at conferences, but not yet published. So they are really interesting. This is the 100-week data. And you have to understand, in the census trial, as in the inbuilt trial, as far as I know, there's a prolongation to 100 weeks in a blinded fashion. So all patients have been on drug or placebo in a blinded way up to 100 weeks until the very last patient had reached the 52 weeks in the clinical trial. So there's a considerable proportion of patients that have continued up to 100 weeks. You see the numbers here, they are really meaningful. And this is the result. Different analysis, intention to treat or on treatment analysis, but you see that the differences are not meaningful. And you also see that the difference between placebo and nintedanib is continuing, arguing that in the second year of application, this effect is continuing. And you also see it's a little bit getting smaller, right? But you also have to understand that there's a patient selection, patients are dropping out, which might play a role into that. But nevertheless, it's continuing into the second year. And now it becomes more clinically meaningful, right? Because then there's a second year of 44 milliliters, and maybe is there a third year? We have some data now on this. This is the census on trial. So all patients being in that up to 100-week census trial were offered to change to nintedanib treatment. And this is the, on the left side is the proportion, the results for the patients that had been in the census trial for up to 100 weeks. You see that's slightly different what I showed in the New England Journal paper. Here it's a little bit more on the placebo group because not all patients continued, but you see that there's a very considerable numbers that continued with off-label, open-label nintedanib. So it's very comparable. Around 100 milliliters, 90 to 100 milliliters in placebo, and around 40 milliliters plus in nintedanib. So let's now see on the right side how they developed for another year at another 52 weeks. So now we are in the third year of treatment, right? Open label. And what you see here, that patients that newly initiated nintedanib that have been in the placebo group of census had almost to the milliliters, again, the same change of forced vital capacity and in the true placebo-controlled trial. So obviously we don't have a placebo group in open label, so we don't know what the placebo group would do here, but it's when they newly start nintedanib, it's almost the same course, which is reassuring. And those that continue have a slightly more progression, but it's far away from the 100 milliliters that we would expect in the placebo group, which we don't have, which we have to extrapolate. Arguing that also in the third year, there's probably an effect ongoing, arguing that in summary, it's probably getting clinically meaningful. Tocilizumab, these are exciting new data that have been published in Lancet Respiratory Medicine a couple of months ago, actually half a year ago. And this is a very interesting trial, but the first very important take-home message that I would like to make, this is a very, very, very different population of patients, very different. These are early, diffuse, there have been a lot of limited patients in the nintedanib trial, in the census trial. They are inflammatory, all had to have CRP or BSR increased. There's skin progression in those patients, which is a link to later progression of lung fibrosis, decline of forced vital capacity. This is a smaller subpopulation of patients we see. Very severe patients, very poor patients. They are inflamed, they are feeling fatigue, they are progressive, they have arthritis very often. These kind of patients, increased CRP, which is about 30% only of our patients. They have been assigned after a promising phase 2 trial in this phase 3 trial, the focus trial, to tocilizumab or placebo. You know the clinical trial design in scleroderma, it's almost a year here. The primary endpoint is skin fibrosis. So let's see what turned out. Nothing on skin, to make that short. There's a p-value of 9%. So there is a difference actually, confirming the phase 2 trial, but that is not significant. By definition, you then have a negative trial, right? But look at the key secondary endpoint, which was forced vital capacity. Look at those effects. First, look at the placebo group to understand how different those scleroderma patients can be. It's 190 milliliters, and not even all of them had lung fibrosis. On HRCT, 2/3 of them had, that was not an inclusion criterion, right? 2/3 of them had lung fibrosis. If you only look at the patients that had lung fibrosis on HRCT, it's 260 milliliters. So now you come in numbers that you know from IPF, right? This is almost an IPF behavior. And you also see the effects of tocilizumab that it, you know, on a group level stabilized to from these 200. That is a big success in this patient population. You know, IL-6 is linked to CRP, though there might be some pathophysiological argumentation that it's working in this group. Also, we haven't tested this. You also see that not all patients respond here from the cumulative distribution curve. We still have 5% that progress with more than 10% FVC. So very, very interesting, very promising. It led to approval of tocilizumab for scleroderma ILD in the US by the FDA. Which was surprising because the FDA, not sure if you had any contact with them, they are super, super strict. There's no primary endpoint, never approved. But this was so convincing, supported by additional measures with HRCT quantification, with other measures in scleroderma. There was a trend for skin, actually. There was a trend for other organ complications. So overall, it was so convincing that to our surprise, they approved this. And I think I agree, because the results are convincing. So what about rituximab for scleroderma, systemic sclerosis, ILD? There were a lot of studies, but look at the numbers here. Look at the open label design. Our study here was a case control study, retrospective even. There's another cohort study with a larger number of patients, 146 from the real life database, but all this is observational. And here only cited, there was a small one-center control trial compared to cyclophosphamide, which showed positive results, but it was an open label and one-center trial. So interesting, but the evidence is much lower than what we had discussed before. But look what happened 2 weeks ago, published in Lancet Rheumatology, and randomized controlled clinical trial for rituximab, randomized controlled with 56 patients that were enrolled, 28 multi-center trial in Japan, actually 28 assigned to either placebo or rituximab without active background treatment, you have to know. So there was no other immunosuppressive. They had to be stopped before inclusion into the clinical trial, besides prednisone up to 10 milligram. And finally, there were 27 and 22 patients completing. So it's a small trial. So let's be a little bit careful. It's not comparable to what we had seen before, but here are the results. And they are really promising and support what had been seen in many of the observational trials. The primary endpoint was skin fibrosis, MRSS, and there is a highly significant difference. The second key secondary endpoint was FVC lung function. There's also a very significant difference with stabilization with rituximab and worsening with placebo. This was a 24-week SUC study, half a year. So some limitations, right? It's a few centers, only done in Japan. It's at the end of the day a small trial with relatively small number of patients. There are some discussions about the patient population, but overall this is super promising, and the evidence has been increasing for rituximab now. So we have many questions remaining, as this is in good research, and this is maybe a research agenda, and Elizabeth has listed a similar research agenda, and we can then use this for discussion, I think, how to address it or how we differently see that. I think we are lacking a lot of important information. So for example, should we do combination therapy? This was one of the questions you had at the beginning, right? We don't have evidence for this, in my opinion. We are missing also primary endpoint positive MMF trials, as you will see from Elizabeth. And Tocilizumab finally was a secondary endpoint positive trial, but not a primary endpoint lung trial. In particular, we are lacking high levels randomized controlled clinical trials on rituximab, but also other treatment principles. And, should we step up, so add medications when there's a worsening, or should we actually step down, start with a combination, and if the patient is stable, then we slowly reduce? Unclear. And please don't compare the effectiveness of studies. We cannot compare the effect of tocilizumab because these populations are so different. We would need a nintedanib trial in early diffuse scleroderma and a tocilizumab trial in the older non-inflammatory population that it had been with the nintedanib studies. With this, I would like to add and hand over to Elizabeth.
Thank you very much, Oliver, for this very interesting and stimulating talk. And now, Elizabeth, for the pulmonologist's view on this very interesting topic. Professor Renzoni from the Brompton Hospital in London. Thank you, Elizabeth.
I'm sorry that I'm having a bit of a problem in increasing the size of my slides. Can you see them?
Perfectly.
Okay, well, I'm going to have to go with the very small ones that I have, and hopefully I remember what is on them. I'm sorry. So this is my disclosure, I'm going to start by talking about the INBUILD trial, which was based on the observation that all ILD entities have a proportion of patients that continue to progress despite optimal management and behave like IPF. And among these are the CTD-ILDs. And this population was the target of the inbuilt trial, so nintedanib in progressive fibrosing ILDs. These were non-IPF ILDs that had more than 10% extent of fibrosis. They were enriched for a UIP pattern, and they had to have declined over 24 months at most, despite, and this is important, optimal management for that entity. And progression was defined in a very pragmatic way, either an FVC decline of at least 10% or a marginal decline in FVC and either symptomatic or CT worsening or worsening in symptoms and CT. And as you can see, in the overall population of all the non-IPF ILDs, divided into UIP and non-UIP, the placebo arm declined much faster than the nintedanib arm. And really the effect was identical in both UIP and non-UIP. It's just that the UIP pattern declined a bit more. And in this study, Wells et al. Looked at the subgroups that were present in the inbuilt trial, and you can see about 25% of patients had connective tissue disease, the majority with rheumatoid or scleroderma, which are, of course, the CTDs that are most commonly associated with a progressive fibrotic phenotype. And on analyzing the subgroups and seeing whether there was a subgroup treatment interaction, none was found, meaning that the nintedanib effect was similar across groups, including the CTD-ILDs. And then we have the RELIEF trial, which instead looked at pirfenidone, again in a group of patients with non-IPF progressive lung fibrosis. Here, the progression was defined slightly differently. So patients had to have a yearly average decline in FVC of at least 5%, measured at least 3 times. They looked at 4 ILD entities, of which CTD was the second most common, again with the most commonly seen rheumatoid and scleroderma. The trial, however, was terminated early because of poor recruitment. This meant that only about a third of patients that were supposed to be randomized were randomized to either pirfenidone or placebo, and therefore that there is a lack of power compared to if it had been complete. And the patients that at the time of termination of the trial, the patients that were still in the trial were withdrawn. And therefore there was a substantial proportion of patients for which data had to be imputed. Despite this, the primary outcome analyzed as per the a priori analysis, so the absolute decline in percent predicted in FVC at the end of the trial in the intention to treat analysis with data imputed by this SDD method was significant, although of course not as significant as an nintedanib, probably because of statistical power issues. And that result was also significant when looked at with different imputation methods, suggesting a similar effect of pirfenidone in these progressive fibrosing ILDs, progressing despite optimal treatment for the individual entity. I now go back to the first RCT performed in scleroderma ILD, and this was oral cyclophosphamide compared to placebo for 1 year, followed by 1 year of no treatment. At the same time, there was a UK trial called FAST, looking at IV cyclophosphamide compared to placebo with similar results. In the SLS1 trial, the most marked difference between FVC change from baseline and between the treated and the placebo group was at 6 months after having stopped the mycophenolate. But that improvement and that difference compared to placebo was completely lost after a year of having stopped treatment, suggesting that we need more prolonged immunosuppression, but with a less toxic agent than cyclophosphamide. And this was therefore the aim of the SLS2 trial, comparing oral mycophenolate against oral cyclophosphamide. This trial did not meet the primary outcome because the hypothesis was that MMF for 2 years was going to be better than cyclo for a year compared to placebo. But both groups showed an improvement which was significant in FVC compared to baseline at the end of the trial. Importantly, an improvement in breathlessness scores and in skin scores, but the mycophenolate arm had a lot less dropouts because of mainly hematological. And so we have seen also from Oliver's talk that there is a great heterogeneity in patients with scleroderma ILD, and this also applies to CTD-ILD overall. We have patients that have limited ILD that will not progress even without treatment. We have patients that can improve on immunosuppression, in whom we can prevent progression, as in the FOCUS trial, or in whom we can slow down disease progression. And as Oliver said, they are very different subgroups, and we cannot compare them directly. Just to say briefly, because we haven't touched at all on the non-scleroderma CTD-ILD, we don't have any randomized control trials in the non-scleroderma. We are basing our actions on retrospective studies and on clinical experience. But as pulmonologists, we are guided by the CT pattern, which can be more or less inflammatory. So the most inflammatory patterns are organized pneumonia, the overlap between NSIP and OP that you see in the antisynthetase. Probably the least, the pattern that has the least contribution from overactive immune system is the rheumatoid arthritis associated UIP. I'm not going to go through these because of time, and we can come to this in the discussion. And what we don't know are a lot of things, but as we've heard, a lot of exciting data that mean that now we have to decide when to do what, because we do have an array of agents. And I'm just, again, going to list these. I'm not going to go over these questions, and there are only a few. But just to say that now the ERS has combined with EULAR in a task force to look at and develop clinical practice guidelines on CTD-ILD. On the respiratory side, this is led by Bruno Cristani and Caterina Antonio, and on the rheumatology side will be led by Oliver Distler and Anna Maria Hoffman-Fold. And with this, I think we can open the discussion.
Thank you very much, Elizabeth. It was very clear. Both the rheumatologists and the pulmonologists give a very nice picture after Helena showing us where we were, how we could evaluate the patients we were facing. So I think we have very important data right now in front of us. And one of the key questions for, I would say, all of us is how to decide. We have so much evidence now, at least in systemic sclerosis.
Yeah.
But one very important question, in front of a patient with systemic sclerosis and ILD evidence on CT scan, say, how should I decide about treatment? So I think I understood from the presentation from Oliver that it will depend. So it depends, of course, of a patient, and but maybe also on the severity of a disorder. At least it was what has been shown by Elena, but according to the severity of lung involvement, we may decide or not for treatment. I would like to have your idea about that, Oliver. Do you think we should decide for treatment only when the disease is severe? Okay, no.
The answer is no, because that's strange, right? Then we would wait until a patient becomes very severe, and then we would start treatment. And I already see Elizabeth saying yes. I think that's not the intention of that nice study that the Brompton Hospital did, right? And Katharina was involved as well. I think it's more adding a risk factor. So if you had advanced disease, you can be even more sure, right, that you need treatment for this patient. But it doesn't mean you should not start earlier. Even vice versa, the Tocilizumab trial is telling us that at least in the inflammatory patients, you should start inflammatory diffuse progressive patients. You should start as soon as possible. And with that data from Tocilizumab, for this population, which is a minor population, right, I would start with Tocilizumab because of that groundbreaking efficacy that we have.
So I understand. Early treatment. Elizabeth, do you want to comment?
Yes, I completely agree. That data cannot be avoided. And I think in the future, we do need to become a bit more like the rheumatologist with rheumatoid arthritis joints. We need to identify the patients that will develop fibrosis and prevent that. For the moment, that is only possible, but as we've seen from the data we have in that subgroup of diffuse, highly inflammatory early disease. I think outside of that group, I completely agree. When it's extensive, unless you have evidence that the disease is stable for a very long time, you would treat always. If it's more limited, that is where the difficulty, and you're not in that subgroup of diffuse inflammatory patients. Of course, the closer you are to the 20% extent of disease, the more you will go ahead and treat. And I would say outside of the diffuse, what we probably are mostly doing now, and I think it's reasonable, is treating with mycophenolate outside of that highly inflammatory group. The question is, how do we recognize patients with limited disease who are likely to progress and are not in that small subgroup of diffuse skin disease? And we need more information on that and probably more trials. As I think we need also trials for Tocilizumab in the more extensive disease. I'd also be interested to see whether it works not only in that group, but later on.
I agree, actually. And another aspect is extra lung manifestations that you have to consider. That's very important, because what I haven't shown in my talk, but it's very important, nintedanib did not have any effects on skin fibrosis, right? So if you have skin fibrosis present, this automatically means that you need something else. And we also use a lot of MMF because there are secondary endpoint and also clinical experience that might be the case. Tocilizumab is an alternative. If you have lung as a leading cause, and this is the only organ you would like to treat, then nintedanib can also be first line, right? Because the phase 3 trials are quite convincing, where patients were without any pre-treatment and the effects were, as I've shown them in the nintedanib trial.
So just to comment on that, on the nintedanib as first agent, I think possibly we need more data for that, in the sense that the census trial was a group with quite extensive fibrosis. So they had to have at least 10% extent of fibrosis on CT. On average, they had, I think, 35% extent of fibrosis. So these are, well, it depends on how they looked at and I know it might have been overcalled, but still, you are talking about at least 10% extent of fibrosis. And so these are patients that are continuing to progress. And even if I'm treating only the lung, unless there is a reason to avoid immunosuppressants, my first choice would remain mycophenolate. The question is whether I would also add nintedanib if there is fibrosis. And I guess this can be a debate.
And there's a question in the audience, right?
Yes.
It's exactly asking, whom are you starting with a combination therapy?
You are once answering to the question of Bettina Schock that is asking about additional combination treatment when you find inflammation. No? So when you have the idea that there is not only fibrosis, but also lung inflammation, for example. So if it's enough to use mycophenolate and nintedanib, or if you have to add something more. No? I think she's perhaps thinking about also steroids that we abandoned in some part of it. So the question is about inflammation. So when you find a lot of inflammation. Oliver, which is the belief of rheumatologists, what you do.
Yeah, I had a quick chat with Elizabeth. I don't know what inflammation means here because, and we don't use steroids in scleroderma. In the other CTDs, we do it because of the association with renal crisis. But I have difficulties to define inflammation. And so I'm more looking at the clinical course and the evidence that we have. And there is a very interesting study from the USTA database that we did last year. And we showed actually that there's an almost unpredictive, what you nicely said also, that there's an almost unpredictable course of the disease. So who is progressing is very, very difficult. Of course, we have risk factors. We have that in mind. And the ones you mentioned actually, right? And also inflammation, disease duration is playing a little bit of a role, etc. Anti-topoisomerase antibodies, you mentioned them all, right? So, and the global experience and picture of an experienced ILD doctor, I think, tells us, yes, this is a patient who will likely progress. And in those patients, I'm starting combination therapy. I'm not making this really dependent on something inflammatory that I cannot measure, except tocilizumab, because we have the evidence in that inflammatory group there.
Yes.
Can I just mention about the inflammatory? Because of course we had this conversation just before this. So I completely agree with you that in scleroderma, we don't have a marker of inflammation on the lungs on imaging. Not really. But in the other CTD-ILDs, and that was the point of that slide. In the other CTD-ILDs, for example, myositis spectrum disorder, which we often see with not that much muscle involvement, because of course they tend to be inversely correlated. But in those, the antisynthetase, etc., you do have a sort of imaging pattern of organized pneumonia, then it moves into NSIP, fibrotic NSIP. Some go on to further progress, some actually do very well. And the same, I guess, is true also for rheumatoid. Sometimes rheumatoid has organized pneumonia on CT. In other times, it's indeterminate. Other times, it's UIP. So I'm not saying it's precise at all, but you can get a feel from the imaging to help you. I agree with you, not in scleroderma, not really. And there you would be more basing on all the things we've mentioned.
We have a lot of questions from the audience, actually. Yes, and we have a lot of colleagues that are following us, and thank you. More than 300 people now online. So I will share with you some questions. Patients who have been using nintedanib with SSc-ILD have been using it for how many years maximum? Nintedanib has been accepted as good treatment in CTD-ILD despite non-impressive results. How long we have to continue MMF for CTD-ILD if patients having stable disease, and what is the maximum dose we can go for progressive patients? From Ines, hello, scleroderma with
maybe we should ask one
yes.
answer for one question, I think.
Yes. Okay. Who would like to?
Oliver, do you want to talk about the length of nintedanib? You probably have the most experience.
Yes. So
and about the quality of the results of nintedanib instances.
I'm a little bit biased because I'm the first author of that New England Journal paper, and I've seen all that. So you're of course every time excited about results where you have been involved closely. So that's my disclosure. But I think I tried to convince you with my slides that this effect that is in this population with a 90 milliliter progression cannot be very large, right? And because it's continuing for up to 3 years, so that's what we have, right? If you include census on, and the quality of data is of course different if you do a 1-year RCT, then a census, and then an open label extension study. But still, when we gather the data, we have evidence now for 3 years that effect is strongest at first year. It's slightly getting less in second year and third year probably, but it's overall continuing with that delta that we have seen. And by the cumulative benefits, I think there is a clinically meaningful effect of nintedanib in stopping progression. We've done more modeling with registry. So overall, I think we have data for 3 years, and that's good. What I'm maybe one last, then I shut up. Then Elizabeth and Elena have to talk. But in my opinion, it's dangerous to wait for progression in scleroderma, right? Because we also showed in that paper that this is a one-year event, or even less than a year, where they progress. And after that, they became stable for a couple of years, and then they progressed again. But in the group level, there's always progression, right? Because some patients are progressing. But on the individual course, they are progressing, then they are stabilizing, progressing, stabilizing. And waiting for that progression period means we miss a window of opportunity, and then we treat maybe with immunosuppressives or antifibrotics for a time period where they might not even progress. So I think we must be better in identifying patients that are at risk of progression, should treat those patients. Difficult to do, I agree, but that is how I'm now applying these different medications that we have available.
So the answer to the question of for how long we have to maintain the treatment in stable patients, I think is you have to maintain the treatment. And that's all, because the real topic, the real aim is to maintain stable the disease, because otherwise it generally go worse. So it's very important that we give the message that we have to start very early the treatment when you find a wide diffuse interstitial lung disease, when you find other comorbidities, and you need to maintain for long time nintedanib as well as mycophenolate if you find a stability of the disease. I think that's the message, no?
I think just to come to what Oliver was saying, I completely agree. We need to be proactive. I think, as you say, the group that is difficult to identify is the one with quite limited ILD. And I know that paper, showing the different rates and stability, then progression. And I guess those are the ones that we can study with placebo-controlled trials, because in the more extensive, now I think you would have difficulty getting through an ethics committee, as there are so many treatments that do work, whereas in the patients with scleroderma with quite limited disease would seem quite right for a trial. And then as you study in the trial, you also learn a lot more about the natural history in a controlled way.
Elizabeth, do you think that we have enough data from the studies that we can combine immunomodulation with antifibrotics?
Thank you for the question. I think the only...
And of course, your opinion about if we have to wait as the inclusion criteria of inbuilt 24 months despite treatment in real life.
Okay, so it's two different questions. Yes. One is combination treatment has only been looked at, and actually not looked at prospectively, but only as a post-hoc analysis in scleroderma ILD. So I think they would be the only ones where we have some data, not definitive data, because that data was post-hoc. But in the post-hoc analysis, it seemed that if you were on neither mycophenolate or nintedanib, you lost about 110 mils. If you were on either of the two, you lost 60 mils, roughly. If you were on both, you lost 40. So there is a suggestion that they work together, but I think we need more data. But I think, like Oliver, in scleroderma ILD with extensive disease, on a case-by-case basis, you could consider this. The second question was, sorry, I forgot.
For the inbuilt, because
about the definition. Yes. So in the inbuilt, the 24 is the maximum that you can wait. But actually, of course, if you have optimal treatment and you decline at 6 months, you would be adding an immunosuppression. The question for CTD-ILD is, how do you define progression? What is the optimal treatment? If someone worsens, are you going to increase immunosuppression, add antifibrotics? Those are all questions that we haven't answered, but you don't have to wait 24 months.
Of course. Mm-hmm. Why? Yes, Bruno?
I think Iris is telling us that we are
finish the time. Stop.
We reach the end of the session. I think we should conclude, Katerina, maybe.
Unfortunately, yes, but we have a lot of questions from the audience that they will be sent to you afterwards. I would like to thank everybody for being with us this evening, and I promise that is the first event and it will be, we will have more, and we have to work more together in this field. And a particular thank you to Oliver for sharing with us all these studies and being with us in respiratory community. Thank you, all of you, my co-chair Bruno, Elena, and Elizabeth, that are the officers of the group of known ILDs. Thank you so much.